speaker for Hematuria, Proteinuria, Dysuria, oh my, Common Complaints in Pediatric Nephrology is Krista Ray. Krista is a family nurse practitioner currently practicing at Ann and Robert H. Lurie Children's Hospital of Chicago in the Division of Kidney Diseases. For the past 7 years, Krista has practiced in outpatient pediatric nephrology, providing care to children and adolescents with acute and/or chronic kidney diseases with a subspecialty focus on pediatric hypertension. Prior to this, Krista worked in a variety of settings, including pediatric acute, primary, and home care, family practice, and also in retail-based health clinics. She received her master's degree at Illinois State University in 2000 and her BSN from Illinois Wesleyan University in 1993. She requests that she's going to have plenty of time, hopefully after her lecture, to answer any questions. There are microphones set up on each side, so if you'd approach those if you have a question for Krista. And with no further ado, would like to present to you Krista Ray.
Thank you very much. I'm very excited to be presenting here today, even though it is Friday the 13th. As I was explaining to Jamie, I was a little leery when I got my presentation date, thinking, oh, Friday the 13th, but I actually had my Friday the 13th on Wednesday when I was 12 hours delayed getting here, so I figured nothing's going to happen today. In fact, I might just throw all caution to the wind and go bet $1 in a slot today. Do something really crazy. Okay, so no disclosures. And the most common referral I see in my practice is for an asymptomatic child with an abnormal urinalysis who has most likely been incidentally noted on a school or a sports physical. So I'm really kind of using that as the framework for our discussion today. And we're going to talk about differential diagnoses associated with hematuria, proteinuria, and dysuria. We're going to identify populations at risk, describe long-term health consequences of kidney disease, and define effective screening tools. So I've been in the kidney division for about 10 years, but I've actually been around kidney disease my whole life. My dad was diagnosed with chronic kidney disease of an unknown diagnosis in his 20s. By his 30s, he was on dialysis, and my mom actually learned how to do hemodialysis in the home setting. In fact, this is a picture of us on vacation. By the time he was in his 40s, he received the gift of hope and had that 1 in a million near-perfect kidney match, and he celebrated 32 years with his kidney, which is almost unheard of. Yeah. Thank you. So at this age, I was absolutely positive I was going to be in showbiz, but clearly destiny had other plans for me. All right, so that's my experience. Let's talk about a patient you're likely to experience. So a 5-year-old female presents for a routine physical. Her UA is significant for large blood, 1+ protein, and small leukocytes. She is asymptomatic. Is this a UTI? Something more serious, or probably nothing to worry about and you wish you had never looked? Well, the number one diagnosis that results from an abnormal UA is, not surprisingly, a UTI. However, that's not always the appropriate diagnosis, and certainly in an era of superbugs and multiple drug resistance, it's critical that we are not overprescribing unnecessary antibiotics. But more importantly, we don't want to make an incorrect diagnosis and miss a child who potentially has something more serious than a UTI. All right, so for those of you in the audience with a really short attention span, I'm going to summarize everything you need to know about nephrology. And that is that the risk and seriousness of a kidney injury occurring greatly increases when you see this trifecta of hematuria, proteinuria, and hypertension all present together. But really, when we see these findings isolated in an asymptomatic child, you can be relatively assured that the etiology could actually be something benign and even self-resolving. Now, the good news is that kidney disease in children is actually relatively rare. And even the number of kids who will present with proteinuria or hematuria is a small percentage. The take-home message I really want to impress upon you today is that to actually diagnose a child with kidney disease off a random urine screening at a school physical is infinitely small. In fact, 99.9% of all of the abnormal urines that you pick up on a physical are actually not really going to be related to kidney disease, but they can certainly cause a lot of parental and patient anxiety and lead to a lot of unnecessary testing. All right, so we're going to do a quick quiz with a show of hands to see how well you guys know your AAP guidelines for urinalysis screening. Okay, so we've got 4 choices. How many think it's to perform the dipstick at age 5? How about 11 to 21? Wow, you guys are smarty pants in the audience today. How about never? Why do I want to create more work for myself? Okay, and how about avoid random screening if the patient is asymptomatic? Very good, you all win. But I know that a lot of people are still doing UAs on every time a child comes in the office because we constantly see them. So in 2007, the AAP recommended that we really get away from doing annual screening on asymptomatic children, but they kind of recognize that it's such a hard pattern to break because a lot of pediatricians and providers grew up kind of doing them as a knee-jerk reaction. So at minimum, they said if you feel like you need to do it, then you can check one at the age of 5 and one between 11 and 21. But really, this is a practice that you can do away with. And the reason being is that it's just not a cost-effective screening tool to use to see if a child has kidney disease. We'd end up having to screen about 800 kids to find that one that has a legitimate finding, and that comes at a cost ratio of about $3,000. Okay? Now, a much more effective screening tool that's also cost-effective is to really focus on the kids that you're doing blood pressures on. Now, the AAP guideline is to start annual blood pressures at age 3. But if you haven't read through this guideline in a while, revisit it because there are a lot of high-risk children that warrant blood pressures before the age of 3 and more frequently than once a year. Certainly, any child you get who has an abnormal dipstick in your office, even if you think it is a UTI, that child has to have a documented blood pressure. And that means that you need to have all cuff size available. I talk to a lot of offices that say they can't accommodate doing infant blood pressures, and that's just not acceptable. You have to have the whole range of blood pressure cuffs available to meet the needs of your patients. Kidney disease is actually the #1 cause of hypertension in kids, which is why it's such a good screening tool to use. And if you feel like you need to brush up on your hypertension skills, and if I haven't completely bored you this hour, I'm talking this afternoon about hypertension, so I hope you'll join me then. All right, so a quick 1-minute review of the A&P of how the kidney works. So on a daily basis, our kidneys filter 200 quarts of blood a day. Of course, eliminates toxins and waste products, balances our fluid electrolytes, and it's important for acid-base balance. Our kidneys help remove certain drugs from the body. And our kidneys also release several hormones that are important to help regulate blood pressure, stimulate the production of red blood cells, and to maintain bone mineral homeostasis. Now, for our kidneys to work, we need 3 ideal conditions. First, you have to have adequate blood flow and perfusion to the kidneys. And the kidneys are actually very sensitive. They're kind of like Goldilocks. They don't want too much perfusion. They don't want too little. It has to be just right. Second, you need healthy kidney tissue. And then third, you need an unobstructed urinary tract. And if we were to look inside each kidney, we would find approximately 1 million nephrons in each kidney, assuming that we were actually a full-term infant. We are born with our total nephron mass at birth, and then as we get age, that nephron mass declines. Now, the nephron is the powerhouse of the kidney, and the glomerulus is the filtering unit, and the tubule is the reabsorption unit. Okay, so when we do a urinalysis, we're getting information about the health of the glomerulus when we're looking at the protein in blood, and we're getting information about the tubule function and how it's able to exchange electrolytes by the pH as well as the specific gravity. Now, kidney disease in childhood has serious implications on a child's growth and development. And it's often what we consider a silent disease because the symptoms are very vague, very insidious, and so can easily be missed. But the number one cause of death in children and adults who have chronic kidney disease that leads to end-stage kidney disease is actually heart disease. And this is for several reasons. Through the loss of proteinuria and the buildup of uremia, you get dyslipidemia, you get a lot of endothelial damage to all the blood vessels, which then leads to platelet dysfunction. We see carotid stenosis and abnormal Dopplers in children as young as age 9 and 10. And as I already mentioned, hypertension is closely associated with kidney disease, so about 70% of kids will have hypertension on top of all those other risk factors. Now, kids with kidney disease also are not going to grow well, and that's for many reasons. The younger they are when they're diagnosed, they actually develop a true food aversion. So often kids with kidney disease will end up with G-tubes, but their growth failure is also caused by anemia, electrolyte imbalances, and endocrine abnormalities, such as disturbed glucose metabolism, resistance to growth hormone, and they do actually tend to develop hypothyroidism. So all of that delays onset of puberty as well as their growth spurt. Children with kidney disease also have bone mineral disorders, and their school performance is affected. If you can imagine a child who is not thriving, who might be chronically fatigued and just not feeling well, isn't really going to be able to focus and do well in school. So any child presenting to your practice who kind of has these vague symptoms or a failure to thrive picture or hypertension certainly warrants that UA screening to rule out kidney disease. All right, some other populations at risk that you want to consider: children with sickle cell disease, children with diabetes, autoimmune disorders such as lupus or vasculitis, children with family medical history of kidney disease, any congenital organ anomalies like heart disease, even as a child with ear abnormalities, because the ear and the kidneys are formed in utero at the same time. So if you see external ear abnormalities or hearing deficits, you might also want to think about kidney. But the number one cause of kidney disease in children is because of some congenital obstructive uropathy. And by virtue of how the male system is designed, males are more likely to have uropathy than female infants. And this is why really appropriately diagnosing and managing children with recurrent UTIs is so critical. Now, two populations that I do want to give a little bit more attention to are our preemies and our children with obesity. And preemies kind of get a bum rap for a couple of reasons. Because they're premature, their kidneys are not fully developed at birth, so they never reach that 1 million nephron mass, okay? In addition, if they were in the NICU for a long period of time, they were probably exposed to several nephrotoxic medications, and they probably have some other comorbidities that cause them to be at risk for developing kidney disease. And there's a lot of interesting studies saying that the more extreme preemies and the really low birth weight preemies paradoxically go on to develop obesity later on in their childhood. And obesity is a risk factor in and of itself for chronic kidney disease. In fact, a study just completed and released by the National Kidney Foundation and Cincinnati Children's just published an alarming statistic that 18% of obese adolescents already show signs of CKD in the form of proteinuria. Okay, so just another reason why the obesity epidemic is so concerning. All right, so let's talk about the dipstick. And just so that we're all on the same page, the dipstick that you do in your office is considered a qualitative urinalysis. It is a screening tool. It is not a diagnostic tool. All right, so the problem with dipsticks is that they can be highly sensitive, but not necessarily highly specific. So those little reactive reagent strips tend to be overreactive. So the numeric values don't always correlate when we do more specific quantified testing. In fact, these test strips can react and give you false positives if the specific gravity on the specimen is greater than 1015, which, considering none of our kids drink, they all have concentrated specimens of over 1015. And those handy little cleansing wipes that we give to all our patients to use are great when we're looking at the presence of bacteria, but not so good when we're looking at protein in blood because it alters the pH of the specimen. And a pH of greater than 6.5 is likely to give you false positive results as well. Now, the other problem with the dipstick is that it can't differentiate between different types of protein, and there are dozens of proteins that are excreted by the kidney. And it also cannot distinguish between the presence of a true red blood cell, a breakdown of hemoglobin, or a breakdown of myoglobin. And I'm going to talk about that a little bit more later. Okay? So for this reason, it is never appropriate to refer a patient to nephrology based on one abnormal dipstick. Okay? You laugh, but we see this a lot. Okay? So for protein, really, I didn't even think that would be a joke, but anyway. So for protein, you have to have at least 2 abnormal specimens, and to confirm blood, you have to have at least 3 abnormal microscopic UAs. All right, now how you collect the specimen is also critical to getting accurate results. So when we're looking at protein in the urine, that has to be based off of a first morning urine specimen that's collected at home and brought to your office, ideally within 2 hours. Now, I know we all feel like when the child's there in the office, that's the time to capture them because the likelihood of them coming back is slim to none. But if you get an abnormal dipstick with protein, your next step is give them a cup to take home and tell that parent that as soon as the child's feet hit the floor in the morning, they need to go in the bathroom, pee in that cup, and bring it to you within 2 to 3 hours. Ideally, it should be a clean catch midstream collection. And it's very important that you and your office staff, whoever's doing the urinalysis, realize that when you're doing a dipstick, that's not the time to try to multitask and dip it and come back 10 or 15 minutes later. These tests are very specific. They need to be read within 30 to 60 seconds to avoid false positives. Now, if you follow these tips, about 50 to 75% of your problems with abnormal UAs is going to resolve. All right, so now let's get into proteinuria. And of all of the 3 topics I'm discussing today, protein is the one that warrants the most attention and is the most worrisome when you see it, even if the child is asymptomatic. And that's because I want you to remember when you see protein in the urine, this is a distress signal from the kidney. It's the earliest indicator of some sort of kidney injury going on. And also, it is the most significant prognostic indicator. You'll see changes in protein well before you would ever see a change in creatinine. Now, protein in the urine on a dipstick is expressed as negative to 4+. And remember, these are not absolute values. These are estimations, and they often don't correlate when we do more specific, precise, quantified urine testing. And any test result of 1+ or greater on the dipstick requires follow-up. And I just want to make a comment here that a trace on a urine dipstick is considered a normal finding. So you don't need to sweat about trace. You don't need to refer them. You don't even need to repeat a urine specimen. Okay? We're worried about those kids with 1+ or greater. All right. So if the dipstick is a qualitative test, sometimes it's necessary to quantify the protein to really determine and confirm our diagnosis. And there are 2 ways to quantify quantify protein in the urine. You can do a spot collection or you can do a 24-hour urine collection. Now, I'm going to discourage all of you right away. Don't even try the 24-hour urine collections. They're tedious, they're expensive. Inevitably, they're not corrected the way they're supposed to be. Try as hard as parents and children do to try to get this right. Someone always misses a specimen or gets the timing wrong. And if you've talked to parents who've had to do this, I mean, everyone in the house is in lockdown for 24 hours. No one leaves the home until that urine is collected. So it's stressful, and kids think it's gross. Okay, so it's very difficult to interpret because of all that unreliability. Instead, I want you guys to really become familiar with ordering and interpreting the urine protein to creatinine ratio. It's very effective, it's user-friendly, and easy to figure out. You simply have the patient drop off their first morning urine specimen to a lab facility, and you're going to give them an order for a spot urine protein and a spot urine creatinine. Now, some labs will actually calculate the ratio for you. If not, you simply divide the protein by the creatinine and you get a number. And as long as it is less than 0.2 milligrams of protein to creatinine, that is a normal finding. So even if you have a dipstick that is telling you this, it has 2+ protein on the specimen, and you send it for a UPC and it's less than 0.2, this result trumps your dipstick, okay? And you can be assured that there really is no protein in the urine. All right, so when you see that child come in with proteinuria, you want to immediately think, are they symptomatic, are they asymptomatic? Now, children with protein in the urine may only have maybe an elevated blood pressure, maybe some edema. So for the most part, you're going to see asymptomatic children, and that's going to tell you that it's probably not anything acute going on. And you can kind of divide them into 3 categories: transient, orthostatic, or persistent. Okay? So transient is a benign condition, not related to kidney disease. Simply means that protein is present in the context of some sort of physiologic stressor like exercise or a UTI, or the child just hasn't been drinking enough, and when you repeat it, it goes away. Now, that's different than orthostatic proteinuria, which is also a benign entity, and this is going to be protein that is excreted when the child is in an upright position, but goes away when the child is supine. And in up to 60% of our kids and even adults, it can be completely normal to see a small amount of gravitational protein in the urine. Okay, but it is never normal to see protein in the urine first thing in the morning, which is why I keep beating you over the head saying it's so critical to get those first morning urine specimens to really determine the presence of protein. Okay? As I mentioned, about 60% of kids are going to fall into this group. It peaks between the ages of 13 and 16, and it's more often found in males. Now, this is a diagnosis you can easily make in your office. You don't need to do a lot of fancy testing. You don't need to refer a child for this. You're, of course, going to confirm that the child has a normal blood pressure, and then you're going to ask them to get 2 specimens for you. First is that first AM specimen, and then you're also on the same day, ideally, going to have them repeat a specimen later in the day, like after school. And when you do the first AM test, you're going to get negative or trace on a dipstick, or if you're quantifying it, it's going to be less than 0.2. But that late day specimen is going to be 1+ or greater, and that's what really confirms that this is a gravitational orthostatic component, and you do not need to refer this patient. Now, the AAP recommends that you can retest their first morning specimen in 1 year just to make sure that there's not been a change in their trend, but after that, you do not need to continue repeating this. And please, on these kids, do not get random specimens because it's always going to be positive, and then you're just going to have this circle of testing go on and on. All right, now the kids that you really want to worry about and catch are those with true persistent proteinuria. So even after determining that you have a reliable first morning collection, you would continue to see 1+ or more on a first morning urine specimen that's 1 week apart. And so this is going to be the definition of persistent proteinuria. And these are the kids that do actually have some sort of renal injury or scarring that's present. And it could be acute or chronic. We tend to think that if you do a UPC and it's greater than 0.2 but less than 2, that's probably more suggestive of something chronic going on. That's kind of more of a low-grade proteinuria, whereas children who will have a UPC greater than 2, that's nephrotic range proteinuria. And that's more concerning because that probably is something that's more acute in evolution. Now, certainly you want to go over any risk factors for kidney disease in this child. Have they had recurrent UTIs? That could be why they have some scar tissue that's developed. Do they have a family history of kidney disease, or what is their past medical history? Were they a former preemie? Management for these kids is going to involve a referral to nephrology, but it's not necessarily urgent as long as the child is asymptomatic and that you've assessed and they have a normal blood pressure and that they're not edematous. But you also don't want to just let these kids go from your office and lose track of them. For our division, a new patient can take up to 3 months to be seen. Okay, so these are the kids that once a month you want to have them continue to come in, make sure their blood pressure is still normal, that they're still asymptomatic, and have them do monthly quantified urine protein testing so that you can determine that if there's any escalation. And at this point, you want to do some diagnostic testing. Now, kidney diseases is very lab intensive, but you don't need to go crazy. Basic testing initially is sufficient. So that includes biochemistries. Now, make sure whatever panel you're ordering, though, includes an albumin, which is not necessarily on a BMP, but an albumin is very important to monitor in the case of a child with proteinuria. You also want to do a CBC, the UPC as we talked about, and in terms of immunology, the one immunology test that's going to give you kind of the most bang for your buck in the outpatient setting is to do a C3, because that could help you figure out if this is a post-infectious picture that you might be seeing or something else. And of course, all these kids deserve a renal ultrasound. And significant lab results include an elevated creatinine, a UPC greater than 0.2, but certainly if it's greater than 2, that's going to be a higher acuity patient. And then a depressed albumin, hemoglobin, and C3. Any of those findings in a symptomatic child are going to result in an immediate consult to nephrology and possibly even a hospital admission. Now, I would have loved to have spent a lot of time talking about nephritis and nephrosis today, but that's another talk for another day. I just wanted to quickly say that nephrosis is a fancy term you might see that simply just means proteinuria, but when we add blood to it, that is when we get nephritis. And nephritis is not necessarily a worse diagnosis than nephrosis, but the presence of blood can certainly freak out parents and providers. So just a couple key points I want to make, whether it's nephrosis or nephritis. You can see if you see a child who looks like this in your clinic with edema, periorbital edema, you can even see the edema in her feet. You know, this is someone who needs to go to the hospital. Nephrosis and nephritis often causes a UPC greater than 2 or 3 or 4 plus on a dipstick. Kids may or may not have edema. They may or may not have a high blood pressure. An elevated creatinine is going to go along more with a nephritis picture than a nephrosis picture. And urinary symptoms, such as a decrease in urine output, can be present in both, whereas you're only going to see that tea-colored urine in nephritis. And both nephrosis and nephritis often present after the child's had some sort of illness 1 to even 6 weeks prior. And certainly a child with fever, joint pain, rash, you're going to think HSP, whereas a fever, sore throat, you might think more post-infectious. As I said, I didn't have time to discuss that, but in your handout, I've included some extra slides at the end that go over both of those diagnoses. Okay? So any picture like this, you need to think there's an acute kidney injury going on, and they need to be admitted and see a nephrologist. Okay, so now we're going to take a step back and talk about isolated hematuria. And the number one rule of hematuria is that it is not blood until it's confirmed on a microscopic UA. You absolutely cannot diagnose hematuria based on a qualitative dipstick. And that's because there are a lot of substances that look like blood that will turn a dipstick positive, and they aren't actually blood. So the most common things that can do that are the breakdown of hemoglobin, myoglobin, ingestion of beets and blackberries, even large doses of NSAIDs, and some types of antibiotics. All of those things could cause a urine specimen to look that color and freak out a parent. And this is why even if it's looks like blood, you have to send it to the lab and do a confirmation microscopic. And in children, it's actually okay for a child to have up to 5 red blood cells per high-powered field on their urine dip. Now that's totally abnormal for an adult, okay, which is why there's sometimes confusion. But to diagnose hematuria in a child, you have to have more than 5 red blood cells on 3 specimens that are at least 1 week apart. And again, 3 to 5 red blood cells is completely normal. You do not need to refer or do any more testing for that finding. Okay. So a tip for a little practice pearl for you is that if a parent brings a specimen like this to your office and you do a dipstick on it, and it says that it comes up as large occult blood, but you send it for the microscopic UA and it's negative and you're totally puzzled by this, well, regardless if it's microscopic or gross hematuria, your diagnosis is consistent with hemoglobinuria, myoglobinuria, or food ingestion. And this is very important for athletes that you might pick this up in, because if they've had an intense workout within 24 hours, they likely do have some breakdown of hemoglobin or myoglobin, and that will affect this urine test result. So ideally, you don't need to refer, but if you think that this is a possibility, make sure the child's not exercising prior to the next urine test. So when you see a child with hematuria, a couple key questions you want to ask yourself. Again, is the child asymptomatic or symptomatic? And kids with hematuria are actually going to have more symptoms than a child with proteinuria. Things like dysuria, frequency, urgency, they might have some flank or abdominal pain, all symptoms that sound like a UTI, right? Which is often why kids with hematuria get put on antibiotics and diagnosed with a UTI, even though that's not the correct diagnosis. It's also important to determine how long the blood has been present. Is this something intermittent, or is it something persistent that's been going on for 6 months? Now, 6 months is a critical time frame because 80% of children who have microscopic asymptomatic hematuria will spontaneously resolve within 6 months. You'll never be able to identify the etiology of what caused their blood, but without any intervention, it'll go away on its own. Kids that have blood beyond that 6-month period of time, then it's more likely that that blood could be associated with some sort of kidney pathology. And then how you see the blood is also going to give you some important diagnostic information, like where is the blood coming from. So when we see, so you can have blood that comes from the upper tract or the lower tract. Blood from the upper tract is going to always be originating from the glomerulus. So that's the blood that we're a little bit more concerned about, okay? Versus blood from the lower urinary tract. It might be more symptomatic and more discomforting and even scarier for the patient or family to see, but it's often due to something that can be resolved, such as a kidney stone, a UTI, or trauma. And I want to make the point that it's very important to reassure parents when you give them this diagnosis that there's blood in the child's urine, because they may not always verbalize it to you, but I can tell you it's kind of always in the back of their mind when I see them that they think this means their child has cancer. And there just is not an association with hematuria and childhood cancers of any kind. So it's important to, really reassure that parent that often most of blood in the urine turns out to be benign. Okay, so some clues to whether or not this blood is originating from the lower tract or the upper tract would be that lower tract is going to be more symptomatic, all those symptoms I went through before. Kids are often going to describe the blood as being bright red in nature or pink, or that they'll see clots, or always consistently with lower urinary tract bleeding is the child will describe that they have drops of blood at the beginning or the end of their stream, but that throughout the void the color of the urine is normal, okay? Now that's different than children who have glomerular bleeding, because they'll describe dark brown Coca-Cola or tea-colored urine, and it's discolored from start to end. Also with the upper tract, you're usually going to see some protein present in that specimen. Okay. Now hematuria, as I said, you need to have 3 microscopic UAs to diagnosis, and once you do that, you need to make sure that this child is normotensive and that they don't have any protein in their urine. Assess the family as well as the past medical history, paying particular attention to any hearing impairment in male relatives or in the child, because you're going to think maybe Alport's disease, kidney stones, which tends to be familial, and autoimmune disorders like lupus are also familial and can present with hematuria. In addition to the biochemistries and the lab testing that we already discussed, you're going to get a renal bladder ultrasound, and then you're also going to send a urine culture on this child. But if they only have blood when you send the culture, you do not need to start antibiotics. Okay? Something else to consider is doing some parental dipsticks. A lot of blood in the urine does tend to be familial, so getting the parents to do a dipstick can kind of help guide you in your diagnosis. Now, these children can be followed up every 3 months until they kind of hit that magic 6-month period of time. And at that 3-month period, you want to do another microscopic, see if the blood is still there. Also do a UPC, see what their protein trend is, check their blood pressure, and touch base and make sure that they're not symptomatic. So, you're going to refer the patient to nephrology if it's been over 6 months or at any time their hematuria is associated with proteinuria, hypertension, abnormal creatinine, a significant family history of kidney disease, or if their microscopic hematuria starts to have breakthrough episodes of gross hematuria, particularly in the context of some acute respiratory infection or ear infection or minor illness. Because those are all possible correlations with a glomerular disease. And the 3 most common diagnoses that come off of a microscopic hematuria are all familial patterns: thin basement membrane, IgA nephropathy, and Alport's. Now, the difference that I want you to remember is that thin basement membrane is for the most part considered a benign and non-progressive form of hematuria. You should not see protein in this child's specimen, and it does tend to happen more in girls than boys. Whereas IgA and Alport's, unfortunately, both of those diagnoses do progress to chronic kidney disease and eventual end-stage kidney disease. They will eventually develop protein in their urine. And as I mentioned before, Alport's is associated with hearing impairment, so it's always important to screen for that. All of these kids, however, can experience episodes of gross hematuria when they're under some sort of physiologic stress. But the most common reason that a child will have asymptomatic persistent hematuria in their urine is from hypercalciuria. And this is just a fancy way to say that the kidney is excreting too much calcium into the urine. And as those calcium crystals are excreted, they're very sharp, they tend to stick together, and so they cause little microscopic trauma and abrasions throughout the urinary tract, and that's why you see the blood. This is a precursor to kidney stone disease, but more worrisome than that is this can cause osteopenia in children, because as the kidneys are peeing out all this calcium, the serum is trying to maintain some sort of homeostasis, so it actually starts stealing calcium from the bones. This diagnosis is not caused by a child drinking too much milk. Okay, it's not in any way related to dietary intake. It is important, though, a child who has hypercalciuria needs to be getting at least 3 good servings of calcium a day to help keep their bone density normal. So all ages can be affected. We even see infants with this disorder, and it absolutely follows a familial pattern. Kids with this can be asymptomatic or symptomatic, depending on how good of a water drinker they are, and it can cause gross hematuria, particularly if they develop a kidney stone. These kids are going to be referred to nephrology. It is not an urgent diagnosis unless you do an ultrasound and you see some great big stone on there that could be obstructing. Then you need to send that child to the emergency room. Now, in between getting this child to nephrology, if you suspect this diagnosis, 2 simple things that you can do. Make sure this child is drinking a good 1 to 2 liters of water a day. The more fluid the child drinks, the less likely these calcium crystals can stick together and cause problems. And you also want this child on a low-salt diet. If we eat too much sodium in our diet, we pee out the excess, and calcium likes to take a ride on salt. So the more salt you eat, the more calcium that's going to be lost in these kids. All right, so if you've been waiting patiently all hour for me to talk about UTIs, now is your moment. So when we talk about UTIs, we often kind of use that interchangeably to mean pyelonephritis and cystitis. But in reality, pyelonephritis is the one we worry about more. It's the one that causes those high fevers as high as 104, 105, and it's associated with renal scarring that eventually leads to chronic kidney disease and hypertension. Cystitis, on the other hand, is going to have kind of more mild symptoms. You typically see this in older children, particularly who are potty training, and it's often found in children who have a dysfunctional voiding pattern. So a lot has changed in UTI management since 2011 when the AAP redid these guidelines. Now they specifically refer to the age group of 2 to 24 months. That's because an infant less than 2 months is going to get a full septic workup, whereas, but an older child, these guidelines still do apply to. But this is the age group that they really wanted to focus on because this is where we might catch that child who has some sort of congenital obstructive uropathy that we need to catch. Okay? So to diagnose a UTI, it is dependent on getting a sterile catheterized specimen. You can't do bag specimens in this age group. It's just not appropriate. But they did change. A urine culture now can be 50,000 to 100,000. It used to always just be 100,000, but you can actually have 50,000 now of a single pathogen. Okay, it has to be a single pathogen. And in addition to that abnormal culture, you have to have an abnormal UA that has lots of white blood cells on it, as well as bacteria. The white blood cells is really the key to this, okay, because that's the body telling you it's having some sort of immunologic response to the bacteria that's present. Whereas we can see some children who have asymptomatic sterile bacteria in the urine, so that's why they made that key criteria. Okay. Now, starting a child on antibiotics is going to depend on several things. If you have a child who looks as sick and miserable as this baby here, you're probably going to start them on antibiotics. The good news is they found that oral antibiotics are just as effective as parenteral for most children. And you're going to start antibiotics pending a final culture only if that child has a high fever, greater than 102, ill appearing, has CVA tenderness, some sort of urologic abnormality, or has a history of recurrent UTIs. Okay? If you have an older child that's not febrile, doesn't look too uncomfortable, you're going to wait until you get that final culture back. The reason being is that there's so much resistance now to even Bactrim. We're even starting to see some cephalosporins and Cipro resistance. So we're going to help lessen the likelihood of resistance developing, get the child started on the right antibiotic when we have that final one back. Okay. In terms of imaging, they really did a lot of looking and evaluating at the fact that really only a small percent of children with a UTI will have an abnormal ultrasound that's significant enough to warrant some sort of urologic intervention. So under the age of 2, every child with a febrile UTI is going to get a renal bladder ultrasound. But over the age of 2, you're only going to get the ultrasound if the child has had recurrent UTIs or if the child has a documented high blood pressure, a failure to thrive picture, or has a family history of VUR. But the news we can all really celebrate is we no longer have to torture every child with a VCUG the first time they have a urine infection. Okay, so, and the reason VCUGs have changed so much is because the management of vesicoureteral reflux has greatly changed. We've pretty much stopped giving prophylactic antibiotics to grades 1 through 3. It's really the grades of 4 and 5 that we are most worried about, because a lot of kids are going to outgrow those lower grades of reflux. So any child of any age who has a first febrile UTI plus an abnormal, oh, I'm sorry, that didn't turn out at all, but it should say an abnormal renal bladder ultrasound, or some sort of atypical pathogen like Proteus or Klebsiella, along with a temperature greater than 102, or again has hypertension or failure to thrive, you're going to do a VCUG automatically on all of those kids. And then any child who has recurrent febrile UTIs, you're also going to want to do a VCUG on. Now, I want to spend a little bit of time talking about dysfunctional voiders, because I think we have a whole generation of them out there. And dysfunctional voiding can present as vaginitis, urethritis, and it can present a lot like a child who has recurrent UTIs. But the difference is, it kind of goes back to what I was talking about. You might get a positive culture, but it'll probably have a couple different bacteria that grow out, or a mixed culture. And you won't see any white blood cells on their UA, and these kids won't have fevers. And the recommendation is really to stop putting these kids on antibiotics, all right? Because their bacteria is really asymptomatic, it's sterile, and what they really need instead is to focus on voiding hygiene. And what that means is they kind of have to retrain their bladder how to respond to the cues, and they have to relearn how to respond to the bladder cues. So that means teaching the parents and the child that while they're awake, they need to go to the bathroom every 2 to 3 hours, regardless if they feel like they have to or not. Now, this is a teacher's worst nightmare. I understand that. So we give a lot of notes, but it's essential for bladder health that this child is not holding their urine for 8 hours every day. You also need to focus on wiping skills, okay? And this is closely associated with constipation. In fact, if you have a dysfunctional voider, chances are they are also constipated, and they have just a total dysfunctional elimination pattern. So lots of water is also going to help not only the constipation, but it's going to help keep their bladder full so that they get those cues that they have to go to the bathroom. Okay, but again, a lot of times these kids too will present with blood in the urine, and you don't want to start these kids on antibiotics until that culture is back, and even then really use that UA as your guideline to determine whether or not antibiotics are even necessary. But dysfunctional voiding is something that certainly can have a lot of impact on the quality of life. It's frustrating often to the parents, and there are a lot of very easy behavioral changes you can make to modify it. Now, of all the kids that we talked about today, there are no restrictions on sports. Even if you incidentally find a solitary kidney on an ultrasound, we don't restrict kids from playing sports. We certainly have a conversation with their parents and with the child about what are maybe some more appropriate sports for them to participate in, other than ones that might put them at a higher risk of kidney injury. But if a child feels really passionate about a certain sport, we're going to find a way that they can participate. Kids, you know, as I said, with the dysfunctional voiders in particular, we give a lot of school notes that unfortunately even end up in IEE plans, which seems like a lot of work to let a kid go to the bathroom. But they do need to use the bathroom. They need to carry a bottle of water during class. So in summary, any child with protein in the urine, you have to confirm with a first morning specimen. Any child with blood on a dipstick, you have to confirm with a microscopic UA, and you need to immediately refer or consult any child who has proteinuria, hematuria, and hypertension. and certainly things change all the time in healthcare, so make sure you're keeping up on your AAP guidelines and reviewing them to help guide your practice. Thank you.